TA. Some of you already emailed, which is great, to sign up for a session. Each TA takes about 5 people. So we'll keep track and we'll let you know if like we don't have any more spots left or yes or no. Um, but you must enable, in order to go into the lab, you must be signed up with a TA. There should be about 10 TAs available each day. Hopefully, with some of our availability is a little bit difficult on days we have something like an OSCE or something like that. So we just have to be understanding of each other. But, and then yes, slides will be sent out after, usually in the group me, and then I'll send an email with like a bunch of them coming up. But yeah, if you have any questions about that, feel free to reach out to us. I know it's overwhelming at first, but definitely sign up for a few because it is very helpful for your upcoming practicals.
Also, in regards to the slides, I've been uploading them to the drive as well. So if you don't see it in the group me, if you don't see it on the email, it'll be on the drive. And maybe from now on, I might just delegate that to your class rep, but we'll still decide on that for now. All right. Cool. So let's get started. Welcome to the spinal cord. You guys are probably already pros at it, but Jenna, you can take it away.
Okay. Um, Sorry. So yeah, spinal cord, this slide is just super, super brief overview. I think the biggest takeaway is that the spinal cord doesn't extend the full length of your vertebral column. It goes from the medulla oblongata, sorry guys. But that's pretty much just a fancy word for the base of your brainstem, which I feel like makes sense. You know that that's like up at the top of your head or bottom of your head. And then it travels all the way down, like through your spine, through the vertebral column, and then it ends before the vertebral column ends, which is around L1. L2, that's when it becomes the conus medullaris, which we'll talk more about in later slides. And then once it goes there, the phylum terminale is what continues on to your coccyx. So brief overview there. It doesn't stay the same thickness as it goes down the vertebral column. It has enlargements, which I think also kind of makes sense if you think about it from like a bigger picture, that it gets thicker when you need more nerves and neurons around where you need to control your arms and legs. So there's a cervical enlargement, which is where you'll have all the nerves that control your upper limbs, and then a lumbosacral enlargement, which is where you'll have all the nerves that control your lower limbs. So those are where those are T4 to T1, T11 to T3. Okay, yeah, and then this is just the cross section of the spinal cord. I think the biggest thing that I kept confusing was that they would refer to things as posterior, but then it would be your dorsal horns. Like those are the same side. And I don't know why that took so long for me to click, but if you need just like a helpful mnemonic, you know, like your PD class, like posterior, dorsal, PD, and then the other ones are just the other two. And at least that's how I thought of it. So you have your posterior median sulcus, and that's the same side that your dorsal horns are on. And then you have your anterior median fissure, which is where the ventral horns are. And I feel like I also got confused with the word sulcus and the word fissure, but they're not the same thing. The sulcus is on the dorsal side and the fissure is on the ventral side. So then I just put some mnemonics. I just used to repeat those to myself, the dorsal sulcus shallow. Um, and then the horns, those are the H-shaped looking things, the gray matter, that's the central of the spinal cord. Um, and then at the very, very center, the like little hole you can see in the photo, that's the central canal, which has your cerebral spinal fluid. So this is just some basic, easy stuff, I think. Yes, they will emphasize that in lab a lot.
All right. And I believe up next we have Rue.
Hey,
Hey,
get me out of
we're
here.
here.
Oh.
We're here.
All right. So we're gonna be talking about the spinal nerves. All right. So I'm a visual learner. I feel like a lot of people are visual. So I just have the picture here, and I'm just gonna explain to you what's happening. And I do have the words on the next slide if you need like that to refer back to it. All right. First, we have the rootlets, right? You have ventral rootlets. Um, And then you have dorsal rootlets, right? The dorsal rootlets create the dorsal root, and the ventral rootlets create the ventral root, right? Are you with me so far? Great. Okay, so the dorsal root, which you can see right there. I don't have the clicker thing, so Brian, you got to help me out. The dorsal root and the ventral root will create the spinal nerve. Okay? Does that make sense? Okay. If you have any questions, let me know. I don't know where everyone is at, so I have to talk to you like this. I don't want you to think that I think that you're anyways. So we have the spinal nerve from the dorsal rootlets, which turn into the dorsal root, and the ventral rootlets, which turn into the ventral root, to come together to form the spinal nerve. Now, the ventral roots, right? The ventral root, I think of ventral like vroom vroom, like a car. It's motor. It has motor fibers, right? So that's kind of like how I think of it, and that's how you can remember it. Ventral vroom vroom motor, a car, and it's going away. Like the car vroom vroom is going away, So and that's efferent, away from the CNS, which is the spinal cord and the brain, central nervous system. It's going away into the periphery. Hope that makes sense. And then the opposite is for the dorsal root, which has sensory information. And it's afferent, so it's going into it's going from the periphery into the central nervous system. Alrighty, so now we're at the spinal nerve, right? So the spinal nerve is mixed. It has both sensory and motor information. Okay, next slide. If none of that made sense to you, I have it all written out here. So every spinal nerve begins as a bundle of rootlets that converge into two roots, one sensory and one motor. The dorsal root, aka, like Jenna said, it's posterior. I love the PD thing. And it has sensory and afferent fibers. It's formed by the dorsal roots and carries, I don't know if you need to know this yet, but just in case, it's never too early. It carries sensory, so that means pain, temperature, and touch from the skin into the spinal cord. And, oh, I didn't talk about this, and it also has the dorsal root ganglion. The dorsal root ganglion, I like to think of ganglion as like a gang of cell bodies. Thank you. Thank you, Brian. So that's the dorsal root ganglion, and it's located on the dorsal root. Get it? Ganglion, dorsal root, okay, cool. Now, the sensory cell bodies live inside of the dorsal root ganglion. So if you get a question that says, where are the sensory cell bodies located, please do not put anything other than the dorsal root ganglion, please. Okay, moving on to the ventral root, aka the anterior, wait, go back real quick, thank you. The ventral root. So it is formed by the ventral rootlets, and it carries signals from the brain and the spinal cord out into the periphery. So there's no swelling, there's no dorsal root ganglion on the ventral root. And FYI, the motor cell bodies sit in the gray matter anterior horn. So just like how the cell bodies for sensory sit in the dorsal root ganglion, the cell bodies for the motor sit in the gray matter of the anterior horn, which is located on the spinal cord. I hope that makes sense. Okay, moving on. I can't see the chat, so let me open that up. Okay. All right, so yeah. Now we're going to talk about the ventral ramus versus the dorsal ramus. So remember, we were at the spinal cord, so we had the dorsal root and the ventral root come together to make the spinal nerve. And the spinal nerve is going to split into the really, really big ventral ramus and the smaller dorsal ramus. So it's not pictured on the left side, but you can see it on the right side that the ventral ramus is huge in comparison to the dorsal ramus, which I underlined in green. And then the dorsal ramus and the ventral ramus, please note that they both have mixed also that sensory and motor fibers along with them. That's why I really like the picture on the left, because you can see that it has the red and the blue and red and blue and ventral ramus and dorsal ramus, letting you know that it carries both sensory and motor fibers. Does that make sense, guys? Are you guys with me? Yeah? Okay, I see some nods. Okay, thank you guys. Good. Good, good, good. If you have any questions, please feel free to stop me at any moment because I'm a yapper. So just stop me at any time. All right. Moving on. Okay, so if none of that made sense, I have it all written out for you. Just beyond the intervertebral foramen, the newly formed mixed spinal nerve immediately branches into a small, tiny dorsal root and then a really, really big, I'm sorry, dorsal ramus and a really, really big ventral ramus, each still both carrying sensory and motor fibers. So the ventral ramus, much larger, is the anterior division of the spinal nerve, and it will interweave with neighboring ventral rami to form the great nerve plexi, aka the brachial plexus, the lumbar plexus, and it'll supply limbs and the anterolateral trunk. It also will give off, which we will talk about soon, the white and gray rami communicans. Okay, so that's the ventral ramus. Now the dorsal ramus, which is much smaller, is the posterior division of the spinal nerve, and that will innervate the deep or intrinsic muscles of the back. And it also supplies the suboccipital region, which I'm not sure if you guys have gotten to yet, but it's basically that area in the back of your head. And I just wanted to give a really cool example, like the dorsal ramus of C1, right, is the suboccipital nerve. I didn't know that. I don't know if anybody else knew that, but I was like, yo, that was like anatomy, you know, a moment there. So that was really cool for me to realize after all these years. I didn't know that. Okay, so yeah, so that's just one example of a dorsal rami. So moving on to the next slide. All right, so now we have the white ramus versus gray ramus communicans. So don't confuse this with the dorsal ramus and the ventral ramus. We already talked about that. We already talked about that. Now we're talking about the white ramus communicans and the gray ramus communicans. Now, so I'm just going to move on to the next slide and then we can come back to this because I think this will be easier. Okay. So the ramus communicans. So when you hear the word communicans, for me, I think of communication. So you know that there's going to be some talking, some chitter chatter happening here, right? So we have the rami communicans link the spinal nerve to the sympathetic, aka the paravertebral ganglion chain, carrying autonomic fibers to and from it. And by autonomic in this situation, I'm talking about only sympathetics, okay? So the white ramus, right, is, please know this for the rest of your life, that the white ramus is only from T1 to L2, okay? The fiber type that the white ramus carries, the white ramus communicans carries, is preganglionic sympathetic fibers, and it's going from the spinal nerve into the paravertebral ganglion, aka the sympathetic ganglion chain, whatever you want to call it. Just know that it's going from the spinal nerve, it's carrying those preganglionic sympathetic fibers from the spinal nerve into the paravertebral ganglion. And it's white, meaning that it's mostly myelinated. So it carries, it's the one that's more myelinated. Moving on to the gray ramus communicans, know that it's throughout all the spinal nerve levels. So how the white ramus is just from T1 to L2, the gray ramus is all throughout, and it is carrying postganglionic sympathetic fibers, and it's going from the paravertebral ganglion, the sympathetic ganglion, into the spinal nerve. And this is carrying unmyelinated fibers. Are you guys with me? Does that make sense? I know that's a lot, but you just kind of have to like take it a bit by bit. Brian, if you can go back to the previous slide. So the white ramus, so just think of the white ramus carrying preganglionic sympathetic, that's the red. And then you can see it, the red is coming from the spinal cord into the spinal nerve and going in through the white ramus into the sympathetic ganglion. It's going to synapse at the sympathetic ganglion and leave out, that's the green, through the gray ramus and back out through the spinal cord, through the spinal nerves, I'm sorry. Okay, I hope that makes sense. So, Brian, you can move on to the next slide. And the next slide. Okay, so this is kind of like the full picture. Remember, we had the rootlets, right? Ventral rootlets give off the ventral Root, the dorsal rootlets give off the dorsal root. The roots come together to form the spinal nerve. The spinal nerve will then branch to give off your ventral and dorsal rami, and then the white and gray ramus will come off of the ventral ramus, and that will be your sympathetic communication. Okay, now if none of that made sense, right, Brian, you can go to the next slide. I made like a little fun situation, like a story. Like I was sitting in the library and I'm like, how can I make this make sense? Okay, so I'm just gonna go through this really quick. I don't want to take too much time, but let's say the spinal nerve and the sympathetic chain are like cousins and they don't talk, like they got serious beef, right? So they don't talk anymore. Something happened. I don't know what happened, but right now they are no contact, right? But they have kids. They got their little cousin, the kids are little cousins and they're chill, like they, dapping each other up. They get along. So their moms don't speak, but they do speak. The little cousins are the white ramus communicans and the gray ramus communicans. Okay, so moving on to the next slide. The white ramus communicans is short, but he's fast. Okay, he's only from T1 to L2, but he's really fast because he's myelinated, okay? And he's carrying preganglionic fibers from the spinal cord into the sympathetic chain. The gray ramus communicans is really tall, but he's extremely slow. So tall because he goes from throughout the whole spinal nerve levels, and slow because he's unmyelinated, okay? And then he's going to be carrying postganglionic fibers from the sympathetic chain into the spinal nerve. Okay, moving on to the last one, putting it all together, okay? The cousins, right? The smaller cousins are messengers, and they connect the spinal nerve into this and the sympathetic chain. These are all of the high yield points that you need to know, and just know that the white ramus communicans preganglionic, right? Sympathetic. The gray ramus communicans postganglionic, sympathetic. Okay, I hope that makes sense. Thank you for listening to my TED Talk. Okay.
Who needs sketchy, right? We got Rue.
We got Roman. She's amazing.
LOL.
Okay, my talk will be a lot more boring. Roman, that was amazing. That's honestly one of the hardest topics to understand, and you crushed that. Like, that was a good review, honestly, for myself. All right, so next we're going to be talking about the cauda equina. A lot of people say it different ways. Sorry if you hear my father in the background. Um, but say it how you want. So we have our spinal cord, right? And that ends around L1 or L2. So you can see that in the picture here. And what that ends as is the conus medullaris. You'll get to see that in lab once you do the spinal cord. I'm not sure what day you guys are doing that, but soon. So that's the conus medullaris at the bottom in red, and that's the end of our spinal cord. So, however, we have nerve roots coming off our spinal cord that have to exit through their respective intervertebral foramen lower down. So even though our spinal cord's ending at L1, L2, we still have all these nerves, spinal nerves that have to come out and exit. And you can see them all coming down um, and out later on. And this group of nerve roots is called our cauda equina. And they say it looks like a horse's tail. You can kind of see all of them coming down together. And they say that the cauda equina occupies the lumbar cistern. What that is just kind of like a subarachnoid. You go over the spaces with Brian shortly, but it's a space in kind of the spinal cord region. It's called the subarachnoid space, and it's just a little bit extra space for them to travel down. And then these nerves specifically innervate a few things, and you might see some questions related to this. So they innervate our pelvic organs, our uterus, bladder, things like that. They innervate a lot of our lower limbs and our muscles there, our anal sphincters, our bladder, and sensory to the perineum. That one's definitely very important because what you will see if you go to my next, yes, perfect. Thank you, Brian. Next slide, what could possibly occur with injury here? um, that sensory to the perineum becomes important. So what they call this and what you'll see in questions is saddle anesthesia. So that means when you're sitting on a horse, think about you're sitting on a saddle and that area that's kind of touching the saddle, that's the area that you'll lose sensation in. So that's why they call it that. Very high yield, yes. And then you'll learn about flaccid paralysis. It means a lower motor neuron paralysis, but you'll get there in neuro. Basically, paralysis of your lower extremities. Can't move them anymore. You'll have bladder dysfunction, you'll see bowel dysfunction, so you'll see a lot of incontinence in people. So you'll see that in questions too. You'll see like a lot of, they'll point out a few of these things and you'll know it's called equina. But just keep that in mind. You'll probably get a question on this. And then we're going to do some meninges. So the meninges are protective layers that are around the spinal cord. So our spinal cord comes all the way down, but has three protective layers surrounding it. And they also extend up into the brain and cover the brain too. But you'll get there later too. So from outer to inner, it's the dura mater, arachnoid mater, and then the pia mater. I have a mnemonic on the next one, just DAP. Like I kind of think of dab, but DAP, I don't know. That just helped me. But we have our dura mater first, and that's the outermost. So that is actually what the spinal nerves are piercing on the way out to go through the respective intervertebral foramen. And that's anchored to the coccyx by our pilum terminale. And then we have our arachnoid mater, which is in the center, and that is avascular. There is no blood supply. It ends at S2. A lot of these end later down like S2. And so we're going to talk about spaces next, but between this layer and the pia mater, that's where we're going to have our subarachnoid space. So that's where our CSF is going to be. So it's dura, arachnoid, pia, but between the arachnoid and pia is our subarachnoid space. And Brian's going to go a little further into that, but keep that in mind. That's where our CSF is. So it's very important for like lumbar puncture and things like that. And then for our pia mater, this one is vascular. And the terminal phylum, people call it phylum terminal or terminal phylum, whatever you want to call it is fine. But it's actually an extension that extension of the pia that also picks up a layer of the dura. And it's that tiny piece at the end of the meninges. So I think I have a picture, maybe not, but I'll take. Is there a picture on the next slide, Brian? Maybe I didn't include it. I thought I did, but if you can just go back. Sorry. And then we have denticulate ligaments, which if you can go to the next one, that'll be good, which suspend the spinal cord. So this will give us a little bit of a better picture. So we have the dura on the outside. That's like the top. You can see it. Thank you, Brian. Or perfect. And then we have the arachnoid, which is another layer inside. And then we have the pia actually overlying the spinal cord. And you can see the rootlets in there that Rue talked about. And what the denticulate ligaments are these white suspensions. You'll get to see these also in the lab. Did we see these in the spring or the fall? Does anyone remember?
This was more spring because that's when they specifically start
Yeah,
asking about spinal cord. But it's good to get,
good to have it,
exposed to
just
a
in
little
case.
sneak peek. Yeah.
But yeah, these denticulate ligaments basically suspend the spinal cord to the dura, so keep that in mind. I'm not sure if I guess I didn't. Is the next picture you? Because I guess I didn't include a picture of the phylum terminale, but that's just you'll see at the end. You'll see it more in the spring, but it's just the end of it. Little tiny little line coming down. But yeah, that's all I have for you guys today. If you have any questions, let me know. I could answer some questions here if you have any.
Which
And
one
once
is
Brian
this?
goes into the spaces, it'll be a little easier to understand everything together. Which one is a space that is only used in injury? Do you mean like when they're getting a CSF puncture?
The
Fake
fake
space.
space. Are you talking
Oh,
about a subdural? Yeah,
yeah. So
subdural
between the
space.
dura, he's going to go over that.
I'll go
Yeah, you
into
wouldn't
that.
normally have a big space there unless there's an injury. So he's going to go through that. Good question. And muscles of the back are going to be on foundations too.
Yes.
Material will be, but in lab on your practical, that's going to come up a little later.
Yeah. So
But the
muscles of
muscles
the
of the
back,
back will be on the
yeah.
exam.
They're gonna be on foundations. We're gonna go over that on Thursday, during our
Yes.
office hours. Um, but yeah, we'll go ahead and talk about the meningeal spaces. So Aaron pretty much laid it out perfectly in regards to the three meninges. We got the dura mater, so a little bit of Latin for you guys. I think this is in Latin. Dura is tough, right? Durable, tough. Mater, mother. So the tough mother is the outside. Arachnoid mater, actually, this one's a little bit of Greek, but it's supposed to be like spider-like. And that's the layer right under the dura, as Aaron already said. And then the very last layer is the pia mater or tender mother. So that's the one that's really soft, really thin, and it kind of just hugs that central nervous system there. So yeah, the epidural space is between bone and the dura itself. So you have the dura mater that, covers that spinal cord, and then the area outside of that is the bone, right? So between those two is the epidural space. This is where you're going to have some fat, the internal vertebral venous plexus that Kylie spoke about in one of the previous office hours. And it's also the space where you'd have the epidural anesthetic. So when they, tell, pregnant patients, we're going to give you an epidural, that's what they mean. That's where you put the anesthetic right into this space. And then, yeah, come on, you were talking, beating the head of the game. We're talking about subdural space here. So this is between the dura and the arachnoid matter. It's a potential space because in reality, do you really see this? Not necessarily. And a lot of times the subdural space is mostly for hematomas that happen. Pretty rare for these subdural hematomas to happen in the spinal cord. Typically, you'll see that in the brain. So when we get into neuro and head neck and everything like that, a little later on and even in early spring, that's when you guys will really see the difference between an epidural hematoma and a subdural hematoma. But this is just to kind of orient yourself with the spaces. And then the super, super high yield one is the subarachnoid space. So this is between the pia mater and the arachnoid mater. And this is exactly where the CSF is located. So whenever we do a lumbar puncture, for somebody who may have a disease, or if we want to kind of have it as a diagnostic, this is where we would collect that CSF through the subarachnoid space. And then I included this from your clicker session here because it's always good. Once again, Latin, right? Sub is under. So for subdural, we're under the dura, and epi means on top. So we're above the dura. So it's just kind of a way to orient yourself. But the high yield point out of all of this is just that you collect CSF from the subarachnoid space. And then we'll go ahead and talk about dermatomes. So what exactly is a dermatome? It's an area of skin that the sensory innervation primarily comes from that one spinal nerve root. I listed off all of the high yield dermatomes because we technically have a dermatome for like the whole body, right? And the reason we have these dermatomes the way they are is due to embryo. So that's something that I think either you guys learned this week or next week with the embryology of the musculoskeletal system. But this is why we have these dermatomes. So pretty high yield. You got C5, which is right here, C5, C6 goes all the way down here, C7, if you guys are flipping me off, that's C7, C8 is pinky right over here, and then T1 kind of goes here, so that's your medial forearm. T4 is a nipple. A lot of times they do ask about T10, the umbilicus belly button area. And then if they ever go into L1, L4, I included those. Do I know if they're that high yield? I'm not sure. I know they love asking about T10. And then of course the upper limb is they also like to talk about. So yeah, do you guys have any questions on anything that I went through here? And once again, dermatomes are strictly sensory, right? So it's just the feeling. All right.
Just a quick thing that I kind of use to remember all the dermatomes because they will come up every freaking module. 5 is if you put 5 fingers over your shoulder. That's 5. 6 kind of looks like a 6 if you hold up your thumb. 7.
Are you flipping me off,
Good.
Kylie?
Yes. And then T10, your belly button's a little circle. It looks like a T10. The nipples, I always think it'd be weird if you had 4 of them. So, and those are your big ones.
That's good. All right, perfect. We can move on.
Alrighty. So now we're talking about blood supply. If you guys can't tell, apparently this is my favorite one to talk about because I keep getting it for all the office hours. So blood supply to the spinal cord, there are 3 arteries. So there's one in the front that sits directly in the middle of the spinal cord and 2 on the back that sit in little crevices in the back that you don't really need to know the name of yet. But if you one, two. Look at them up. So the one in the front is going to supply the anterior 2/3 of the spinal cord, and the posterior ones are going to supply the posterior 1/3 of the spinal cord. Both the anterior and posterior spinal arteries are going to get extra blood, like supplemental flow, so you never lose blood supply to your spinal cord. They get it from the posterior intercostals in your rib area. In your neck, it'll get it from the deep cervical, like some lumbar segmental arteries, artery of Adamkowitz, which we talked about last week. That's a huge high yield that they love to ask about, like where it is and when it supplies. It's about the level of T10 to L2. And then you have all your vertebral arteries that come off. And then they also get reinforced by segmental spinal arteries, so the segmental spinal arteries come off the spinal artery. So either the anterior or the posterior spinal arteries. The segmental spinal arteries become the segmental medullary arteries. And those all kind of connect straight off the aorta to the ones that supply the anterior and posterior spinal. So it's kind of a hodgepodge, but if you kind of draw it out, you see that these T10 is your belly button. Sorry, I have the chat huge over here, so I couldn't not see it. Anyways, so if you draw it out, your main ones to know are your anterior and posterior spinal arteries, and then just kind of being aware of all of the collateral flow that you can have through there. And then venous drainage, it's a little bit more complicated. I think the important thing to know about this is that it's kind of like a highway for infection sometimes, because the valveless one that we talked about last week, but this one has more protection. So there's the anterior spinal vein. When there's an artery, there's a vein that has the same name. The anterior spinal vein goes to the anterior segmental medullary vein, which goes to the intervertebral vein, which goes to the epidural venous plexus, which goes to the basivertebral vein, and then that all drains into like major systemic veins, like the azygos vein or whatever major systemic vein that it can catch closest. Veins will always go with whatever is closest to them. These aren't super high yield. You should be aware of what veins are there, but I wouldn't say that knowing the exact flow is vital for this section. So I would just know kind of where in the chain they fall. So like coming straight off the spinal artery, or the spinal cord is the anterior and posterior spinal veins. They will directly drain blood from the spinal cord. Yeah, that is it for me. Any questions about blood supply or venous drainage? I know I did it kind of fast because there's not too many arteries. They're just kind of know them. Okay, no questions. Good.
Okay, so now I can talk about some of the clinical correlates that they want you guys to focus on. So the first one is compression of the spinal nerve roots. So a big thing that your slides emphasized is that the lumbar nerve roots increase in size as you go down, but their exit gets smaller, which I think kind of makes sense. Like if you picture the curve, like as it's going, these exits are just going to get smaller and smaller. So you can kind of think about it a little logically there, but that just makes it harder for something bigger to fit through. So it can get compressed a lot. The slides emphasized L5 just because that's where the biggest nerve root is coming out with, and it's the smallest hole. So that tends to get compressed a lot. And I know in past TA reviews, we talked about disc herniations. Bone spurs are kind of the same thing. It's just compressing the spine. Honestly, just a different word for it. You'll pretty much same vibe. But yeah, when you do get a compression, you'll see it along the dermatomes, which was what Brian talked about, which is why it's really important to get those down. You'll need them the entire year. But they can also affect the motor of your nerves, but I think particularly for the lower limb, you guys don't have to worry about the motor and the muscles until MSK2, so you have a little time, but just know that it can have sensory and motor effects when you compress the spine. But yes, and then the next one, lumbar puncture. So we all kind of talked earlier about the meninges and how the spinal cord ends before your vertebrae ends. So pretty much whenever you're doing a lumbar puncture, you really, really, really don't want to touch your spinal cord. So that's why they do it so low on your back, because they want to do it below where the spinal cord ends. And pretty much lumbar puncture is to when you want to remove the cerebral spinal fluid. They just want to check like things for that. I kind of am blanking on why they would do that right now. Anyways, not very important. But you would put your needle, the common spots are between L3 and L4, L4 and L5. You don't know, you have to know the difference between why they won't give you both of those options. They would either give you one or the other or anywhere in that range, just because it's below the spinal cord. And to tie in some OMM, your iliac crests are your L4 landmark. So a lot of people, they'll have you do that. In lab. I don't know if you guys have done it yet, but it's kind of like your hip bones. So like doctors will actually go and feel there to kind of have a landmark before they go in. Um, and one thing that your slides semi mentioned is that the last area that the needle punctures before it gets into the lumbar cistern is the ligamentum flavum. I know this was a question on one of our exams because I got it wrong and I was so mad. So pretty much know that that's the last ligament that the needle goes through before it reaches this space. I know that we've talked about like all the things of the spine on the previous TA sessions, but just want to emphasize, really know that in case they ask it again. And then, oh, Semi talked about epidural anesthesia already, but you also have spinal anesthesia. The only difference is where the needle stops. So for the spinal anesthetics, you're going to the subarachnoid space, and epidural, you're just going to the epidural space. You can kind of think like spinal S, subarachnoid SS, epidural, epidural. And I think this photo does a good job of showing where the needles stop. You can see that the top needle there is the epidural needle because it's stopping in the epidural space, and the bottom one is the spinal anesthetics because it's going farther than that past the meninges into the subarachnoid space. And one potential risk with the spinal anesthesia is just because it's deeper, you can get a headache. Your cerebral spinal fluid can leak and just cause some problems. So one of the things that you can see pop up in like a question stem is that you get a headache, and that is connected to the spinal anesthesia. Sorry, I'm seeing the chat questions pop up, but I can't see them. I don't know why. Oh, okay, got it. Why would you do one of the other? Yes, and Kylie got it. Thank you. Yeah. Epidural, just think like classic. I feel like the connection is when you're giving birth and you don't want to feel anything because it's extremely painful. So you do that to numb the area. And the subarachnoid space is to collect the cerebral spinal fluid to do. I think people answered what I had forgotten, like to collect information from your nervous system and whatnot. How do you Oh, this is actually kind of fun. I feel like, and a lot of times, they emphasize that you can hear it pop. So I feel like that is the big sign that a lot of doctors use to tell when they've gotten in to the epidural space is that they can like kind of hear the ligamentum flavum pop. I feel like that is a big word that they use in a lot of stems. Um, I don't know how they tell to get to the subarachnoid space. Maybe an ultrasound. I don't know, maybe two pops. I'm not too sure. I have never done one before or seen one, so I'm not sure. Oh, that makes sense. Typically ultrasound. But yeah, I do know that they emphasize, or like in the stems, they sometimes put that the word pop, if that answers your question. Yes, the lumbar puncture does go into the subarachnoid space because you're trying to pull the cerebral spinal fluid. Um, and that's why you would do that. So you want to get deeper to get the good stuff.
Oh shoot, this is me, my bad. Um, okay. Y'all are quick. I think the email just went out for Open Labs and I have mad people emailing me right now. But that's great. You guys are quick. All right, so again, you guys know my policy, you know my rule. We all read the question together and then put your answer in the chat. So, a patient presents with a small, well-defined patch of numbness and tingling on the skin over the lateral forearm with no associated weakness. Where would you expect to find the cell bodies for the sensory neurons responsible for the sensation? Okay, so feel free to put it in the chat if you know what the answer is. Okay, we got a lot of C's. Somebody said dorsal root. Let's see what the correct answer is. Good job. You guys are paying attention. So the correct answer is dorsal root ganglion. I would just be careful not to say dorsal root because dorsal root is a thing. So make sure you say dorsal root ganglion to specify that those are where the sensory cell bodies are located. So great job. Classic test taking tip is to read the last sentence first if that's what you're into, because literally you didn't need any information prior to the last question, the last sentence. The last sentence tells you what the question is asking for usually. So just a tip for you when you're taking questions, especially if you're crunched for time. Moving on to the next one. All right, immediately after the dorsal and ventral roots unite to form the spinal nerve, what happens next? So the spinal nerve terminates directly in the paravertebral ganglion. The spinal nerve becomes purely motor, losing its sensory component. The spinal nerve redivides back into the separate dorsal and ventral roots, or D, the spinal nerve splits into a smaller dorsal ramus and a larger ventral ramus. What is the correct answer? Good job. Okay, next slide. Good job. Yes. Sorry, Brian. The spinal nerve splits into a smaller dorsal ramus and a larger ventral ramus. Great job, you guys. I'm pretty sure everybody's going to get an A on that exam. All right, moving on. A 32-year-old undergoes a paravertebral, aka sympathetic chain block at the level of T4 for suspected complex regional pain syndrome. The anesthesiologist explains that fibers travel from the spinal nerve into the sympathetic ganglion via a specific communicating branch before the drug takes effect. Which ramus does this describe? And what is the key feature of the fibers it carries? So A, is it the white ramus communicans, carries unmyelinated postganglionic sympathetic? Oh my God, it's a lot. You guys can read it, please. Don't make me read this whole thing. But yeah, feel free to put the answers in chat once you know what it is. So the question is asking which ramus does this describe? All right, so I'm seeing a lot of C's. White ramus communicans carries myelinated preganglionic sympathetic fibers. Amazing job. Great job, guys. Now, this is a type of board style question that you might see on the exam. You know, it's giving you that clinical vignette, but then at the same time, it wants to know whether you know like the characteristics of a certain part of the spinal nerve. All right, moving on to the next question. I don't know if this is the last one. Okay. A patient has an injury affecting a mixed spinal nerve. Shortly after it exits the intervertebral foramen, the patient develops both weakness of the skeletal muscle and loss of sensation from the skin supplied by that nerve. Which statement best explains this finding? Is it A, spinal nerves contain only sensory fibers, spinal nerves contain only motor fibers, spinal nerves contain both afferent sensory and efferent motor fibers? D, sensory and motor fibers travel only within the sympathetic trunk? Or is it E, motor fibers enter the spinal cord through the dorsal root? All right. Okay. Okay, so let's talk about this. All right, let's talk about this. So the correct answer is C. Good job. Spinal nerves contain both afferent sensory and efferent motor fibers. I think I took this question from your anatomy. You know the questions that they give you guys before each mod. So there you go. That's how you know this is going to be a question on your exam. So definitely make sure that you know this. And it seems like you guys really know your stuff. Great job. Keep it going. I don't know. Let me see how if I have another question. Okay, that's it for me. But before we move on, guys, just make sure you know where the cell bodies are for motor and sensory. Make sure you know where the mixing happens in terms of sensory and in terms of motor. So that starts at the spinal nerve, right? And it goes throughout the ventral and dorsal rami. So make sure you know that. Make sure you know what afferent sensory and efferent motor mean, like how it goes into and out of the central nervous system. Make sure you know which ones carry the preganglionic versus the postganglionic sympathetic when it comes to the white ramus and the gray ramus. White ramus, that's the unmyelinated one. It's the preganglionic sympathetic, and the gray is the white ramus is the myelinated, gray unmyelinated, and the gray is carrying the postganglionic sympathetic. If you know that, you should be set for that portion of the exam. That's one or two questions right there. All right, so good luck, guys. You got this.
Do we know who made this question?
I have been doing so many reviews in office hours lately that I completely forgot that I wrote questions for this one. But anyways, a medical student is reviewing the arterial blood supply of the spinal cord, which artery provides the major blood supply to the anterior two-thirds of the spinal cord. Whew, a lot of talking today. Sorry, guys. Hey guys, looks like you're doing good. It is the anterior spinal artery, and then I have one more. I do remember now. Nope, not mine.
I think this one is mine. So patient sustains an injury at the L4 vertebral level. Which structure is most likely to be injured? Okay, good. I'm seeing a lot of you put C. That's good. I think the main thing I wanted to emphasize here is that I used to get the conus medullaris and the cauda equina confused a lot, and like the conus medullaris is still technically part of the spinal cord, so that ends at like that L1, L2 level, and the cauda equina is what extends after. It's just oh, I think this is mine too. Um, so a silly student examines a spinal cord cross section but accidentally rotates the specimen. So which figure would be, or which feature would be the best to help them identify that they were looking at the ventral surface of the spinal cord? Wait, you guys are right. I think I just highlighted the wrong answer. I'm looking at I didn't even, it is the fissure that's on the ventral surface. I don't know what I was thinking. Don't ignore that. You guys are right. You're gonna do really well.
We'll
Oh wait,
also
this is mine.
yeah, we'll
This is
correct
mine
that
too.
before we send out the slides, by the way, but
Yes.
no worries, no worries. They sound the same. It's calm.
Brian, do you want to just like exit out, correct it now, and then open the PowerPoint back up? Because I think there was a few questions added to the end that might need to be reloaded too.
Oh, really? Like recently?
Yeah.
Let
Mhm.
me, ah,
Oh, Lord.
ah,
Here you
ah.
go. Oh, you got it, Grandpa.
Yeah.
Oh,
Okay,
perfect.
I got it. I got it.
Sweet. So then we can slideshow this bad boy up again. Perfect. And then bam. All right. And now,
Oh, sorry, this might be mine again. Um, a doctor wants to obtain a sample of cerebrospinal fluid without risking direct injury to the spinal cord. Where can they put the needle and why? Sorry, I realized I made another mistake. I was making these at like 11 o'clock last night. If you want to, here, wait. You're right. It should be L4, L3 to L4 because the spinal cord ends at L1, L2. I think I ended up going back and like changing the wording of the question and not ever changing the answer. I will fix that again before we send this out. But if you want to go to the next I highlighted, it is A because pretty much it's not any of the other options. I was trying to get that you want to go below where the spinal cord ends, which is it ends at L1 to L2. So you want to go below that. I should have reread these. I'm sorry, guys. Oh, and this is me. Last one I think I have, and hopefully I didn't mess up the answer on this one. So this is just some identification for which side is ventral, which side is dorsal. This might be a little hard. This is a little more lab based, but I think we kind of touched on it. Okay, yes, I think I'm seeing some A's, and that's the correct answer. So the way I like to think about it in lab is that you can kind of see the gray matter like come out and kind of touch the border of the spine on the dorsal side. That's how I used to identify, but also you'll be able to see a big distinction between the fissure and the sulcus. So I know some people use that because depending on like where you're looking at the spine, as you can see here, it can be really tiny and really hard to see the gray versus white matter. Um, so these images kind of make it pretty. Um, but yeah, that's just more lab-based review. Go back to the last key technically tell by the H. Yeah, yeah. So you can definitely tell by the H. Like the part, as I was saying, the part that kind of connects to the border of the spinal cord. You can tell that that is the dorsal side. And where it doesn't connect, like where you have white matter between the gray matter and the edge of the spinal cord, that's usually the ventral side. Not usually, always the ventral side.
and this is a good sneak peek for neuro as well. These kind of questions won't go away. You'll see this again spring semester. So it's good that you guys get some exposure now for sure. I think this might have been me. Is this me? This might have been me. All right, cool. So a 24-year-old woman undergoes a lumbar puncture for suspected meningitis. The needle is inserted at the midline. Actually, is this me? I'll just take it. It's fine. Which structure is the last to be penetrated before the needle enters the space containing the CSF? This is quick. Come on. Yeah, that's what I'm talking about. Yeah. Easy money, right? The ligamentum flavum. Well, okay. So yeah, the structure is the last to be penetrated before the needle enters the space. So the reason this is arachnoid matter, right, is because it's going to be in the subarachnoid space. So yeah, it got me too. So see, that's a good question. This is not easy money. But honestly, it's a good reminder. It's a good reminder to read the question very carefully, right? Because if it said the last ligament, as Aaron said, it would have been C, but the last structure is the arachnoid matter. So she's absolutely right. Yeah, so Miriam, so what's going on is it's actually just a wording thing, right? When it says which structure is the last to be penetrated, the last thing you're penetrating, technically speaking, is that arachnoid matter. But the ligamentum flavum would be the last ligament that you pierce. So
I have
it's
no
a
idea.
little bit
I'm
of a
scared.
Maya, you're unmuted.
hey Maya, you're unmuted. Give you a heads up. Yeah, cool. So yeah, does that make sense? It's just like a wording thing. Yeah. But it's a good question. That's a good question, Aaron. So yeah, I believe this was also me. All right. Good stuff, guys. So this is pretty much the extent of how they're going to ask these dermatome questions. Um, you see that it says, numbness extending across the dorsum of the foot, great toe, L405. Actually, this might have been Aaron again. Actually, I don't know who it is anymore.
I
But
didn't make this, but I can explain it.
if you want to, I don't know. I'm losing track.
We did talk about this last week when we have our disc herniations. We're going to be going posterolateral, and we're always going to affect the nerve root below, because if you remember the photo where that disc is coming out, the L4 nerve root already exits above that. So just it will be L5 for this one, which you guys got.
Yeah, good stuff. Who's gonna flip me off? Right? Yeah. There we go. There we go. We're back. We're back. Let's read this question carefully. Which nerve root? Yeah. Good stuff, everybody. C7. So you could do this to your friends, just a way to remember. C5 is going to be this area here. So it's kind of like the upper shoulder, lateral, kind of upper arm area. So it goes C5, and then it goes C6, C7, C8 is like around here, and then it goes T1. Yeah. Good work, everybody. Oh, Aaron, you got a shout out.
This is mine. TA Aaron receives
Oh, gosh.
anesthetic in the epidural space, but TA Kylie receives anesthetic in the subarachnoid space. So which TA requires the needle to penetrate the dura and the subarachnoid matter? Good. I'm seeing some B switches.
I like this question.
And then I added this picture again just because I like this so much. I went back and found it from my notes last year. I thought it was super helpful. But yes, I think you guys got it right. Oh, and my last one, same stem, but which one would be more likely to have cerebral spinal fluid leak through their puncture site? Yeah, seeing some B's. Yes, it is also Kylie, just because when the subarachnoid space, that's where your cerebral spinal fluid is. So that's where you're more likely to upset some things, stir some things up, and it could give you a headache.
Perfect. So it is 7:02. I don't want to go into another TA office hour time. So I'll stop sharing my screen. Does anybody have any questions for us before I let you go? we're gonna send out these slides. Would we need to know specific arteries for each divided semispinalis and ilicostalis? That could be a question when it comes to written. Definitely won't. I don't think they'll ask you that for the practical. It's a little too specific. But it could be a question for the written. It doesn't hurt to know it, but if you're crammed on time, it's not something that I would